Good afternoon. This is Dr. Ogochiko Lozzi, the Chief Health Informatics Officer here at Texas Tech University Health Sciences Center, El Paso. I will be discussing today the digital future of healthcare. And I think in this manner, we're just going to dive right in and look at some of our objectives. So today, we'd like to talk about the dynamic healthcare landscape. What is digital health? And what is the future of healthcare going to be like with technology interwoven into it? And with that, I'll just dive directly into a definition.
I'm often asked, what is digital health? In simple terms, digital health is the convergence of both the digital and genetics revolutions with health and healthcare. The essential elements of digital health include wireless devices, hardware sensors and software sensing technologies, microprocessors and integrated circuits, the internet, social networking, mobile and body area networks, health information technology, genomics, and personal genetic information. The underlying lexicon of digital health is extensive and includes all or simply the digital and/or health-related elements of mHealth, also known as mobile health, wireless health, Health 2.0, eHealth, Health IT, big data, health data, cloud computing, e-patients, quantified self and self-tracking, wearable computing, gamification, telehealth and telemedicine, precision medicine and personalized medicine, plus connected health. As we are seeing and experiencing, digital health is empowering us to better track, manage, and improve our own and our family's health. Digital health is also helping to make healthcare delivery more efficient, improve access, reduce costs, increase quality, and make medicine much more personalized and precise. This is an incredibly exciting time. I encourage you to learn more about digital health, try for yourself any of the many solutions available to consumers and healthcare workers, and catalyze the digital health revolution.
And so I often ask people at this juncture, how did digital health affect you? And many times people say, well, I'm not really sure. I don't know. I knew somebody that used a patient portal. And those are all really valid answers. But I often ask them, do you have a fitness tracker, right? A Garmin, a Fitbit, an iWatch. And even if you have none of those, your simple smartphone is tracking everywhere you go, how fast you go it, and the locations that you're at, right? So those are the kind of things that will start to catalyze what digital health really looks like. Many of you will remember the game Pokemon, right? Came out a few years ago, had people running all over airports and all over parks looking for Pokemon characters. Well, all that running around actually increased steps. It increased steps 30 to 60%, depending on the piece of this market that was being looked at, right? And so what if we were able to use that engagement or gamification and get people to move or engage with physical therapy or move on a diet plan or post-operative care, right? These are all potential options that exist out there. So I always think it's important, before we have a conversation about where we're going and what's changing, where are we now? And it's important to note that healthcare is huge. It's a third of total federal spending, and it's expected to be almost 25%, almost 40% by 2025. It is growing for a host of reasons. I mean, medical inflation, aging baby boomers who used to be the largest part of our population, that's now millennials, increased utilization. Here in El Paso, we'd easily be able to give examples of utilization where we see freestanding ERs and urgent cares popping up all around the place, right? And not to say that these are bad things or these are poor quality. They're driven because of the need for efficiency and accessing care. But again, I often tell people, if you have a URI, an upper respiratory tract infection, and you go to the emergency room, your average bill is probably going to be between $2,500 and $5,000, depending on where you live in the country. If you go to an urgent care for the same complaints, maybe $1,500. If you go to your primary care doctor, it's a copay of $50, total bundle, maybe $180 to $200. And you can see the scales of magnitude engaged in various venues with the same complaints. And our desire as a society to have things quicker, faster, and more efficient is driving a lot of this. And I think employers who cover half of our population, they're going to continue to move costs. My deductible today is not what my deductible was 5 years ago, nor is it what it was 10 years ago. And that's all affecting our healthcare system. $3.2 trillion. And there are multiple players in this ecosystem, from the payers, the insurance companies that I referenced, your employers. Me as a provider, I'm responsible for probably about 20% of it. Hospitals, 30%. You can see what pharmaceuticals are. And the politicians play a role. One thing that you rarely hear people really talk about or focus in on when we talk about the amount of money that our healthcare system is worth are the patients, the people that are actually the sickest, the people that we're trying to help get healthy, right? In that relationship between provider community and patients. And that's going to drive a lot of the changes in healthcare as we continue to move forward. Nationwide, multiple trends. I boiled it down to three. Cost-effective benefits, partnerships, and integration. Read that as trying to cut what I get paid, right? And I say that cynically and a little bit facetiously, but in a lot of these partnerships, the reality is the payers on either side, whether it be employer insurances, are realizing that healthcare is expensive and they need to find ways to reduce that cost. That's being introduced in ways such as P4P or ACOs, accountable care organizations, or Medicare shared savings plans, whatever it may be called, right? A lot of it is cost cutting, cost effectiveness. They're looking for partnerships. As a clinician community, a lot of organizations are realizing that, number one, there just are not enough physicians to go around to the amount of people that need care. And number two, if you actually want to give care in a much better way, you need coordinated care. You need to have interdisciplinary team approaches. Gallup historically does a poll every year, and they ask, who do you trust in the professional world? Is it lawyers? Is it engineers? Is it doctors? I'll tell you right now, doctors almost never come first. It's pharmacists and it's nurses. They rotate 1 and 2 literally every year. And so I often tell people when I talk to them, if you're creating an integrated care management team, or you're trying to do PCMH, or you're trying to do hospital rounds that are multidisciplinary and integrated, and you're not including your nursing staff and your pharmacists, you're designing your system to fail. And I think that's very important to note. And we're back to those patients that I talked about. They're becoming more engaged as healthcare consumers. And there's a host of debates as to whether a patient is actually a consumer or they're a patient. And I think it just depends on how sick they are, how potentially needy they are, what are their needs in the system. But again, the fact that much more of their deductible is being pushed back to them, much more of their healthcare costs is being pushed back to them. The average family is expected to pay between a quarter and a third of their gross income in healthcare if they get sick, right? It's the number one cause of bankruptcies in America. All those things and the changes in our generational divide between baby boomers, Gen X's, and millennials are going to change the transparency in how we engage with healthcare. And this is just, again, showing that Gallup scale that I mentioned. And so nurses, pharmacists, doctors, just food for thought. And specifically where I am in El Paso, a little bit different than other cities our size, right? High volume of Medicaid. About 60% of ambulatory patient care is provided by small groups, 2 to 4 docs, and they're utilizing almost 50 different EMR systems. You want to talk about a Tower of Babel, right? That's right. That is exactly what that is right there. And unlike Houston, where there may be a Methodist and Memorial, they drive a majority of the health care in aligned systems within Houston, the same thing doesn't happen in El Paso. And so whether you go to an HCA or a Tenet or a UMC El Paso hospital, when you come out, it potentially is a crapshoot on who's going to engage you in your primary care or your surgical follow-up care or your diabetes care or your mental health care. And each of those individual practices is not connected. And so you can imagine the amount of faxes, imagine fax that we're still talking about in the 21st century, but the amount of paperwork and information that goes from organization to organization. Many of you historically have played a game at some point in your lives where they say, start a story at the beginning of the room and see what it ends up at the end of the room. And that's at the end of the room. Talk about across cities with PDFs and faxes. None of those things are amenable or conducive to actual coordinated and improved healthcare. The landscape here is also shifting rapidly, right? The Hospitals of Providence, which is the Tenet organization here, they're buying practices. There's more consolidation. We're seeing for the first time accountable care organizations or ACOs and Medicare shared savings plans or MSSPs entering the market in an attempt to align providers and ensure that patients move through certain systems with a degree of efficiency. And there are new market forces as well. If you had asked people 5, 6 years ago whether private companies would be coming into El Paso to develop ambulatory health care, they probably would have said no, that the hospitals is where all the money is. But we now have Privia, Comedics, and MCCI, which is actually a payer, has recently opened up a health clinic here, and they're trying to get as many providers and physicians as aligned as possible with their patients. And so we know where we are, but how did we get here? And it's been a circuitous journey. Right? The United States healthcare journey is not straight, and there's a host of reasons for that. I'm not going to belabor this slide or go through every point, but I think one thing that I will jump to is World War II. At the end of World War II, when the vets and GIs started coming home and started having all those babies that led to the baby boomers, they were looking for work. We had an industrial boom, there were jobs aplenty, and employers looked for hooks to get the best employees. One of those hooks was insurance. They would offer insurance as a differentiator between themselves and somebody else, Ford versus GM, GE versus IBM. Right? And so that was great, but what does that leave unaccounted for in terms of insurance coverage? You're right. The elderly at one end and kids, right? That's Medicare and Medicaid. And of course, the disabled, the unemployed, people of lesser means, that goes into a lot of Medicaid at times too. But that was really what it turned out to be in terms of insurance. And I'm going to fast forward. By 1997, we had approximately 16% uninsured. Now, this is not a political conversation, and so I'm not going to get into pros and cons of Obamacare or ACA, whatever your nom du jour happens to be. But at the height of Obamacare, multiple reports said that we had cut that down to between 8 to 10% of uninsured. Right? So again, just different ways that we've gotten to healthcare. Unfortunately, with all these changes in our healthcare system, multiple reports show that we don't do the best in terms of performance. And if you add the cost on top of performance, then we really have a problem, right? If I charge you $100,000 and I give you a Maserati, or if you're a motorcycle person, a Bugatti, you may be happy. But if I charge you $100,000 and give you a Beetle, probably not going to be the expected result. You and I may have a problem. And so think about our healthcare system in terms of that. We're paying for a Maserati, getting a Beetle, and this is a problem across the board. And so we understand the landscape is changing, but how exactly is it changing, right? So we're an industry in transition. Historically, whether it was the hospital that was in the center, there were physicians, there was long-term care facilities, skilled nursing facilities, ASCs or ambulatory surgical centers, home health, and that was complicated enough. Add to that multiple layers, whether it's cancer centers or physical therapy. There's venture capitalists getting into it. There's Watson, there's genomics. All these things are making healthcare very, very complicated. And so I like this slide because it really shows where a lot of that innovation is and whether it exists now or when we expect it to exist. All right, and so if you haven't heard of telehealth, and vendors such as American Well or In Touch Health, you really need to know that because it's actually probably one of the top two fastest growing sectors of our healthcare industry, which is telehealth. Applications such as ZocDoc, which is a way for you to go online, figure out what you're trying to look for, what your insurance is, and ZocDoc will give you providers that have appointments within the next 24 hours that you can do a direct book into, right? The data and predictive analytics, which we'll talk about, multiple companies getting into multiple spaces, and you look 4 or 7 years out, that's a conversation we may have later about what is blockchain going to do to the healthcare? What is artificial intelligence, right? How are patients going to enable their e-visits at home and using ultrasounds and cardiology equipment to get their information to their physician from home without having to come in? And again, these are all disruptors, right? So all these things here, whether it's ZocDoc, retail clinics, urgent care centers, or ambulatory surgical centers, were all thought to be poor quality in the beginning, right? The established players, the big hospitals and big systems all said, no, poo-poo that. These guys can't do what we can do. We've seen with ambulatory surgical centers, not only can they do it, but sometimes they can do it faster and at a lower cost, right? And so there's a lot of churn between hospitals and ambulatory surgical centers when it's not owned by the hospital about who should be able to do what and who should get a facility fee. But we are where we are. Urgent care centers may cost more than going to your PCP, but they cost less than going to the emergency room. and they give you what you want, which is efficiency, right? Retail clinics, the clinic that was at Walmart or the one that CVS has integrated into Target, those are all things that are disrupting the way we see care and engage with care. And understand this, healthcare is not the most vulnerable to disruption. On this curve, it's actually number 9. And we can easily think of examples of disruptors in the industry. So in retail, we would think about Amazon. Walmart used to be the number 1 retailer in the United States, and it's now Amazon. When you think about technology, think about the 10 years of the iPhone from 2007 to 2017, and look at the form difference and the speed difference and how much we've come to rely on our phones. And in media and entertainment, often we think of Netflix. And why is that? How has Netflix disrupted the industry? As of last year, Netflix had more people watching it during prime time than TV. And imagine how that affects how people advertise and watching patterns. A couple of reasons that this has happened. You probably know internet speed changed, right? We went from dial-up to 1G to 2G, now we're up to 4G. So the speed of the internet increased and the ability to buffer or lack of buffering and getting downloads and streaming became a real thing. I think the other thing that's just important is that the form factor changed. We went from watching TV and movies at home on a TV, right? And now we do it on our phones or our tablets, depending on how big it is. But we want mobility, we want efficiency, and this has changed not just technology, but will start to change healthcare. And so what is this digital future of healthcare? I really believe the future isn't what it used to be and will continue to change. And so one thing about that video that I often point out to people is that as apps came into the economy, what happened behind them? And you would have noticed that those organizations or those businesses disappeared. And so nobody would ever expect that Toys R Us, would be coming to an end, right? Filing for bankruptcy. And so I often tell people, you may not believe that this is going to affect your hospital or your clinic or the way you practice, but don't get caught like the Titanic. Start to turn now before you hit that iceberg. Start to dabble. I often laugh when executives say, well, we can't afford it. Or is it going to bring us money? What's the ROI? When you changed from dial-up to T1s, there wasn't any ROI on that. When a lot of academic health centers put in libraries, there's no ROI on that. It's operating cost, and it has to become OPEX. You need it to stay competitive and to stay alive in the changing future of healthcare, right? No matter what kind of budget you have, there have been cuts. And so again, convenience is winning, and this will continue to drive healthcare as well, whether it's Uber, Kayak, StubHub, OpenTable, or Amazon. The issue or the concern with healthcare, and I don't think it's a concern, but the opportunity for those of you who want to embrace it, is that there isn't a thing. And maybe you can become that organization that creates that thing. Many of you know that this is Michael Douglas, and his character in this movie was Gordon Gekko. Greed is good. The name of the movie was Wall Street. The question I often ask is, well, do you know what's in his hands? And people will laugh and say, I think that's a phone. It was called the Brick. Averaged about $5,000, $2,500 to $5,000, depending on where you were. And I once upon a time said that only old guys had it, until I found out that some of my professional colleagues who are older than me, so I just say my venerable colleagues. But the point is that that was a phone. It was very expensive, and all it made was poor quality calls. Now, think about the form factor that you have as a phone. It fits in your pocket. It has GPS. It can stream. It can make phone calls, high definition videos, and a plethora of the millions and millions of applications that exist out there. And patients and physicians are now using a phone as a mechanism of having a visit. Here in Texas, we now know that legislatively it's legal. And people are positioning and jockeying to create infrastructure around telemedicine and how they're going to engage in that space. And so I talked about the iPhone, and John Noseworthy, the CEO of Mayo Clinic, once said, "We believe Apple's Health Kit will revolutionize how the health industry interacts with people. We are proud to be at the forefront of this innovative technology with the Mayo Clinic app." And it wasn't just Mayo Clinic. When Health Kit came out and then Research Kit, clinical trials that would take months to years to enroll hundreds or thousands of people enrolled tens of thousands of people within 24 hours on the heart study that was on the iPhone. Think of how that changes how you do consents, how you do pre-visit planning, how you do research. And if you poo-pooed that, the fact that about 3 or 4 weeks ago, Apple also announced that in the iHealth app, they were partnering with 13 of the largest healthcare institutions in the country to give the power back to the patient. Remember, that patient we talked about that is rarely discussed. This is how this starts to pivot. Giving their information back to them. They determine what they have. They determine who their provider organizations and individual providers are. And then leverage that to then give it back to another organization, right? I think recently they've upped that. Apple made an announcement either yesterday or today that they're up to 39 organizations and expect that to continue to grow. Now, many will poo-poo this as it's just another Apple gimmick and stunt, and it may be, but it will drive the industry and other competitors in this space to get better at it. It'll drive people to use HL7 and Smart on Fire, and maybe it's blockchain, whatever the case may be, to try to move information securely and efficiently and to give it patient-centered. We as healthcare organizations shouldn't necessarily be the arbiter and mover of their clinical data. In a perfect world, that would be the patient and not us. And so that's just food for thought. Also understand that whether it's Google, Amazon, or Facebook, Facebook may be having some issues after their recent debacle, but they're all ingesting your data. They're all trying to get as much information on you as possible to target you, and that's not going to change in healthcare. And this is personified by the fact that the CEOs pictured here announced just 4 weeks ago that they were getting into healthcare to try to fix it for their millions and millions of employees, right? So Jamie Dimon, Warren Buffett, Jeff Bezos, JP Morgan Chase, Berkshire Hathaway, and Amazon respectively. And let's make no mistake, they are getting into it to save money on their own side and improve their efficiency. But if they get into it, I'm sure Jeff is going to find a way to sell it. And you probably will buy it because it'll be faster, more efficient, and there'll be transparency around the pricing. And so again, if you're in a healthcare organization and you're not thinking about these concepts, how do I get more transparent? How do I get more efficient? How do I get more patient-centered? Yes, the world you live in is profitable right now. But again, nobody believed that Blockbuster was going to go away until they disappeared. And again, just food for thought. And so in terms of health data sharing, it's Google, Microsoft, Samsung, Apple that usually are at the top. You can already see that Facebook was not really at the top anyway in 2016. And after their recent debacle, I'm sure nobody's going to really want to share healthcare information with them. I'm going to jump to another video that's very intriguing, and we'll go from there.
Technology has given us an unprecedented window into the human body. But on a day-to-day basis, we're still in the dark about our own health. We are changing that.
You okay? Do you feel okay?
What if instead of fearing the worst when you notice something out of the ordinary, you could identify the condition yourself? Getting the right diagnosis would save you worry
It says it's roseola.
and an unnecessary doctor's visit.
Rest at home. It's okay.
Instead of hearing about a viral outbreak on the news, imagine you got an alert that was tailored to your family's needs. It would also give you advice about what to do next. What if you had a way to identify what was wrong right away?
It says it's 103.8.
A way to get all of the information you need to understand the situation. And in serious cases, you would know when and where to seek help.
Yeah, it recommends taking it to the urgent care.
We're building a way for people to check their bodies as often as they check their email. It's all possible, and it's only the beginning.
Now, at this point, I often ask people, if this was real, would you use it? And it's always interesting to me, the splits, right? So I've come to realize that in people my age and above, it's probably about 30% would say they use it. They're used to the status quo. It's what they want to engage in, and they like what they like. When I give this kind of talk to high school students and undergrads, majority of them would use it. What's always intriguing to me is when I give this kind of talk to medical students and pharmacy students, you go back to that 30 to 40% only that would use it. And it's always intriguing to think this through, and often they have been tainted by healthcare. They've been tainted by the status quo, and I use taint not necessarily as a negative term, but they've been tainted by the fact that we teach them not to think like that, to go to the doctor, to go to hospitals. We teach them the status quo. I'm going to skip another video and I'll come back to it in a bit if we have time. But I think winners and losers in digital health, you can see them. Those of you who are already in practice or involved in the costing and payment systems around healthcare already know that reimbursement's going down. People are trying to reduce inpatient stays. And if you're a radiologist or own a radiology company, you know that your payments today are less than they were 5 to 10 years ago. But that doesn't mean there's not opportunities across the board, whether you're an HIE or an FQHC or an integrated delivery network or a payer or a clinic. There are multiple opportunities across the board that you can engage with. And so the future, what is it? I think one of the things that we have to think about with the future when we talk about the patients and how this is changing is that millennials are now the largest part of our population, and they engage with healthcare very differently. Baby boomers such as my mom minimally own a wearable, hardly go online to find a doctor, don't look at reviews, it's word of mouth. What did their neighbors say? What did their friends say? And they'll make a lot of phone calls, right? And I'll skip my generation, which is Gen X, but go to the millennials. A lot of them own wearables. Almost half go online to find a doctor. And remember, this is the generation of plus ones, likes, and stars. When they come into an area and they're looking online for services, they're looking for those that have the highest ratings. And so if you're not managing your social media profile as a healthcare organization, you're not setting yourself up for long-term success, because a lot of these applications are based on that. And again, if you're engaged in the decision making around your healthcare IT infrastructure and you're not focusing on creating video infrastructure over the next 2 to 5 years, you're really getting behind and you need to change that. And so those are just some suggestions. Again, apps are going to drive engagement. They're disrupting the marketplace. Consumers will get what consumers want. As I mentioned, telehealth is, I think, the second largest and fastest growing part of the healthcare industry right now, and will only continue to grow. What does the future look like going forward? I think this is where we are today. We have big hospitals, superstar docs, own it or do it all. But everything's still in silos, right? Between doctors, hospitals, home health, hospice, SNFs, and we pay. If I see 100 patients, I do better than if I see 10 patients. I do believe that over time, as we pivot to fee-for-service, as artificial intelligence actually begins to enable clinicians to do better, the Radiological Society of America has probably been the one that has adopted technology the most. And I give people the example of in an emergency room. If you're a radiologist in an emergency room, it's usually first image in, first image out. But what about, instead of seeing 100 images, right, and having to go through them in the queue unless there's a code or a motor vehicle accident or some sort of trauma, you have artificial intelligence that's able to identify fluid, blood, or dissection and say, hey, doc, by the way, These 4 images need to be looked at now because these people are critically in danger. The other ones I've done an initial screen on and you confirm. Right? Those are the kind of things that artificial intelligence and artificial decision support can start to assist us in and change the way. And again, genomics and the science of how are we actually developed and made from gene technology will also give us very targeted care over time. I love this slide because it really does speak to me. Medicine has been a clinical science supported by data, whether it was Grand Rounds or New England Journal of Medicine articles or JAMA articles. All of you that are in medicine or healthcare know about these articles that would have 50 to 250 patients in them. Now we're talking about the data of thousands of people aggregated together, actually able to show us insights, and not just insights, but potentially generalizability, right? Is it really proper to take a clinical trial with 250 people and less than 2% African Americans or Hispanics and generalize that across the board? But if we had 10,000 African Americans, maybe even 10,000 Nigerians, 10,000 Cubans, 10,000 Mexicans, right, from Mexico City, in a trial or an observational cohort, we can actually splice that data a lot better. And with the big data and analytics capabilities that are being developed, makes it very simple. Those of you know all these connections. It's one of the things that health information exchanges are trying to do, connect us all together. And I think it's critically important that those connections and interoperability continue to grow over time. The healthcare system of the United States is difficult, it's complicated, and since we do have some time, I'm actually going to go back to my video because I think this is how healthcare could be going forward. And I will fast forward for the sake of time to the part that is intriguing.
Visit documentation complete and finalized. Proposed E and M level 99214. Do you wish to close the encounter?
Yes, please.
Dr. Davis, your next patient is in room 120. He presents for his annual physical exam and follow-up of hypertension. Recent encounters include one acute visit 2 months ago with your nurse practitioner for a sinus infection. He last saw you 8 months ago for hypertension follow-up. He has been reporting his home blood pressure readings monthly on the patient portal. Would you like to review those readings?
Yes, thank you, Iris.
Please note, Dr. Davis, the patient had a CBC done at his acute visit 2 months ago. The hematocrit had fallen 12% from his baseline. Attempts by staff to contact the patient for follow-up were unsuccessful.
Thank you for the heads up, Iris. Please remind me of that if I get sidetracked in there. By the way, what was his wife's name?
Grace.
It's good to see you again, Mr. Lee.
Good to see you, Doctor.
It's been a little while.
Yeah.
How is Grace?
Oh, she's well. You know, our youngest just got married.
That's wonderful. I remember that she just got engaged the last time I saw you. I see you're here for your annual checkup. Thank you for reviewing the medications and symptoms in the waiting room. Is this list correct?
Yeah, this looks right. Except I'm no longer taking the sinus medicine. And, oh yeah, by the way, I'm running low on the atenolol.
Iris, can you remove the loratadine from the medication list and renew Mr. Lee's atenolol?
Mr. Lee, do you still prefer a 90-day supply to be sent from your mail-order pharmacy 4 times a year?
Yes.
Dr. Davis, Mr. Lee's blood pressure is 152/93. His pulse is 62 and regular. Do you wish to review before finalizing the prescription?
Yes, Iris. Mr. Lee, your blood pressure's a bit on the high side. And you can see, over the past few months, even at home, your blood pressure's been climbing steadily. Have you been taking the atenolol and the Diavox?
Which one is the Diavox?
Diavox is the orange pill with the letters NVZ stamped on the side.
Oh, that's the one that I've been cutting in half.
Okay, let's increase the dose of the Diavox and have you take a full tablet every day. Your heart rate is nice and low already, so we'll keep you on the same atenolol for now.
Dr. Davis, as of November 4, Mr. Lee's medical insurance will no longer cover Diavox. Would you like to substitute a different angiotensin II blocker?
Okay, how about the equivalent dose of losartan?
Losartan 100 milligrams daily will be added to Mr. Lee's mail-order prescriptions.
Now, Mr. Lee.
So I think you get the point. And I think really, as a physician, that's what I would like in my visit. Not having to type, being able to engage with my patient, keeping eye contact, and having them verbally commit and confirm when questions come up that don't need to be documented. Now, obviously, some of you have scribes, some of you have Dragon, but think about this as an amalgamation of all of those things and taken to the next level, really. Whether it's medication adherence, whether it's those of you who are doing HEDIS programs understand that changing a 30-day to a 90-day is the best way to meet that HEDIS measure. All those things woven into one. And with that, I think we've taken a nice journey here in terms of what healthcare may be, what it's pivoting to, and the factors that are driving it. Technology has an immense opportunity to improve and make things efficient, but always remember, technology cannot replace your people and your process, right? I often say PPT. People, process, then technology. Your people have to be on point. You have to have a process that works, and then use technology to enhance it. Thank you very much. This is my contact information for those of you that want it and need it, and I appreciate your time. Have a great day. Bye-bye.